Good afternoon. Thank you for being here today. I know many of you are students in 201, so you have to be here, but for everyone who's joining us from the broader Rice360 community, we welcome you. My name is Yvette Maribel. For those of you who don't know me, I'm the Executive Director of Rice360, and we are excited to welcome you to a very special, first ever Global Health Seminar panel featuring our Rice360 alumni. We're old enough now that we actually have quite accomplished alumni, and as a side note, these are all former students of mine when in the early days of Rice360, when I was back then called Beyond Traditional Borders. So today we are joined by 3 distinguished alumni who participated in Rice360's Global Health Technologies undergraduate programs and who have gone on to robust, notable careers. We're thrilled to host them back at Rice for a conversation about the intersection of global health and diverse career paths across fields like medicine, technology, and policy, and for them to share how their studies in global health technologies at Rice shaped their career trajectories and how the lessons they learned continue to influence their work today. Our first panelist is Dr. Alex Bonnel. Alex is an internal medicine hospitalist at Pennsylvania Hospital in Philadelphia. He received his bachelor's in sociology with a concentration in global health technologies from Rice University in 2010. During his time at Rice, he served as Weiss College president. Alex received his MD from Baylor College of Medicine in 2015, followed by an internal medicine residency at the Hospital of the University of Pennsylvania. During residency, he completed the global health track at Penn, which allowed him to rotate through Princess Marina Hospital in Botswana and the Suhutsuhi Medical Center in Fort Defiance, Arizona. After finishing residency in 2018, he became the first internal medicine graduate to pursue the Penn Point of Care Ultrasound POCUS Fellowship. During the POCUS Fellowship, Alex gained experience teaching ultrasound both at home and abroad and continues to do so. He has served as an expert trainer in POCUS courses in the United States, Bangladesh, Uganda, Rwanda, and Yemen, through collaborations with NGOs. Alex also volunteers as an attending physician at Puentes de Salud, a charity clinic for undocumented migrants in Philadelphia. Christina Lagos graduated in 2018 from Rice with a bachelor's in biochemistry and cell biology and a minor in global health technologies, and followed in 2019 with a master's in biomedical engineering through Rice's Global Medical Innovations Program. She currently works at Proximate Clinical Research, leading a team of associates and specialists who research, strategize, and compose documentation for clients and the FDA. She also serves as the portfolio manager, assisting over 300 companies for the Southwest National Pediatric Medical Device Innovation Consortium and is passionate about helping medtech innovators successfully navigate the pathway to market. And finally, Christina Triantaphyllis received her bachelor's in biological science and health policy from Rice University in 2008. Following her graduation from Rice, she earned a master's of science degree from the Harvard School of Public Health in global health and population, where she was a Reynolds Foundation Fellow in social enterprise. Christina brings extensive experience in building relationships with leaders, both in the government and nonprofit sector, to improve social outcomes. Previously, she served as Chief Officer of Public Policy and Strategic Initiatives at the nonprofit Collaborative for Children, where she led public policy efforts to strengthen the Texas early learning system and developed data-driven program strategies to inform policy priorities. Christina is also a co-founder of Pair Houston, a nonprofit providing educational services for resettled refugee youth, which I believe she did when she was an undergraduate at Rice. Alex, Christine, and Christina exemplify how an interest in developing sustainable healthcare solutions for low-resource settings can spark a lifelong passion for global health equity and access. These 3 incredible alumni continue to make an inspiring difference in health equity around the world. We hope this panel will highlight the versatility of a background in global health and show that Rice students can and do take what they learn in their time here far beyond the hedges. I now hand the microphone over to Rice360 Director of Education Strategy, Dr. Carolyn.
Thank you, Yvette, for introducing everybody, and thank you all for being here. Thank you everyone else for being here as well. Today we'll have these amazing alumni talk to us about their journey at Rice and beyond, and what they'll do is they'll give us a 10-minute presentation to get started, and then I'll ask a few questions that you all submitted. student of 201. And once we have the questions, we'll also open it up to the audience to ask more questions, and I'll end it with another question. So lots of questions happening here today. And then after that, we'll have a happy hour at Capella. So to get started, we'll start with Dr. Alex. No. Okay, there you go.
Can you guys hear me all right without the microphone? I just prefer not to use the mic when I'm talking. Okay. Oh, that's me. Okay. I haven't been here on this campus in 10 years, so the nostalgia is really intense today. I'm really, really happy to be back. And I want to talk to you guys about going from Rice360 to global ultrasound. So as mentioned, I'm a physician at Pennsylvania Hospital, but I'm going to talk more about what I do outside of that hospital because it's much more global in a sense. So I just want to take you to a case that I recently saw about a few months ago. Recently, it was a 32-year-old woman who was at a refugee camp in Uganda and was coming to our clinic with 6 weeks of lower abdominal pain. She had 1 week of vaginal bleeding and had basically acute worsening of lower abdominal pain. So her vital signs were fine. She, on exam, was tender a little bit in the right lower quadrant of her abdomen. She had a positive urine pregnancy test. And, the differential at that point was, is this an ectopic pregnancy? Is this appendicitis in pregnancy? Is this an infected kidney or urinary tract infection that went up? Unfortunately, the only diagnostic tests we had were a rapid malaria test, a rapid HIV test, and electrolyte levels and blood counts. So not really much to help you figure out what's going on inside this woman's abdomen. And just to give you a sense of where we were, this is essentially the health facility here. This is our ambulance to transport someone an hour away for any emergencies. So that's where I think this really amazing technology comes into play, which is the butterfly ultrasound. So that's this little ultrasound device here, which I have with me today as well, in case you guys want to see it later at happy hour. This little device basically connects to your iPhone or connects to an iPad and gives you decent quality ultrasound images, which you can use in really remote areas. So here, we're able to ultrasound and take a look, and I'll show you. I don't expect you guys to know what this is. Does this video play? Let's click. No, it doesn't play. Let's do this. No, but no one here's a sonographer, so no one's going to really know what I'm looking at anyways. But basically, this is a view of someone's uterus from the side, and as it pans through, there's a pretty large mass that shows up in the right ovary, as well as all of this swirling blood in the abdomen. So that combination of those two things leads to the diagnosis of an ectopic pregnancy. So the solution here is to take her to the operating room and take out that tissue, otherwise she would keep hemorrhaging. So from such a simple, small device, we were able to save this woman's life that day. It was a pretty amazing turnaround. Where if we had not had it, we would have sort of hemmed and hawed about what could be happening. It's not really what you think about diagnosis after 6 weeks of pain. It's a little unusual. So maybe we would just probably send her out, and she could have easily gone home and died later on that day. So pretty amazing turnout for that little device. So I want to talk about how I went from the quad here to rural Uganda, and I'll try to summarize my entire last 15 years in 8 more minutes. So the lessons I wanted to share with you guys are that Rice360 was an incredibly invaluable exposure in college. That failure is an important part of growth, and changing directions doesn't mean that you have to change your values of what you are or who you are. So just as a sort of summary of my college experience, I started here in 2006. I did the BA, as we mentioned, in sociology, and then the minor in global technologies. I did this great study about a program through Northwestern that was based out of Paris that focused on public health in Europe. It was a really fantastic course. And I was Rice College president, which was awesome. And obviously lots of fun. Year back 2009. This is us turning a truck into a pig. This is a photo from study abroad. This is the rugby team I played with. And this are all the college presidents my graduating year. So fantastic memories that I'm reliving today. So going back to 2010, right after I finished college, I did the Rice360 at right that time. It was called Beyond Traditional Borders, and sent me to Botswana. So I went to Gaborone, Botswana to test out my device. My project was a pill counting device, and then we also had a GYN screening in a backpack. So basically this whole thing would fold up into a backpack that you would take to rural sites in Botswana. And my goal as the young undergrad was to basically do these things work? What do people think about them? What's the feedback? How can we make these projects better? I met incredible mentors at the Baylor Children's Health Clinic. I mean, these were fantastic pediatricians who had just finished residency and did, as part of the Baylor International Pediatric AIDS Initiative, got a grant to live in Botswana for 2 years and work in global health in a very nice clinic, and also just an incredible group of people that were there. So super fantastic mentorship for someone who was trying to figure out what to do with their life to be exposed to. So this is the path I imagined, which many people also share. Come to Rice, they think I'll go to medical school, then I'll go to residency, and then maybe I'll do Doctors Without Borders, I'll join the WHO. and that's what I had wanted to do probably from age 17 onwards. But then come August 2010, I get waitlisted at 11 medical schools and get into none of them. And I'm in Botswana, like, what am I going to do now? This is my whole plan. I had this clear path of going to be a physician, but now it's totally rerouted since I didn't get into medical school. So one of these women I worked with in Botswana, she was a Penn undergrad, and she sent me an email saying, hey, there's a job opening at the Penn Transplant Institute that you can go work with this guy, Raj Reddy, who writes paper after paper after paper. I applied, got the job, wrote a bunch of papers with him, and you guys probably know how weird the medical school admission process is, the things they value, et cetera, but they really like the fact that I wrote some papers, and then finally let me into medical school. So I came back and went to medical school, and so I went from the Penn Transplant Institute to Baylor across the street, and finished medical school and went on to match to Penn for internal medicine residency. I'm going to fast forward to residency because I think that's where some of the global health exposure comes back. So there's a global health track here which sent me back to Botswana, which was really fantastic to go back to the exact same place I'd been before, because I got to see how the site had developed in only 5 years. When I first went there were 0 residents, 0 medical students. When I came back a few years later, they had a full residency program. They had an incredible academic presence from attending physicians, and just a very impressive program they built in only a few years. So that was also really inspiring to see how you sort of get accustomed to how things don't improve, but this was actually a really great exposure to see how things really did improve in such a short period of time. I discovered point-of-care ultrasound, which I'll talk about what that is in a second, and I had a whole lot of fun because it's residency. It's exactly like Scrubs. It's exactly how you imagine it. It's not like Grey's Anatomy. It's a lot funnier and more entertaining than that, actually. So point-of-care ultrasound, what is it? So it's a diagnostic tool that's performed by the clinician at the bedside. So it can be a physician, it can be a physician assistant, it can be a nurse practitioner, but some clinician. It doesn't replace comprehensive radiology. It's a very focused question. So here, for example, you have your ultrasound machine with the probe. The person's probably wondering, what is this person's heart doing? We take a quick look at it. It's not a thorough, comprehensive radiology study, but it's a focused representation of what's happening inside the body. So now let's fast forward to 2017. There's this new device that comes out, which is the Butterfly. The big difference between the Butterfly and your traditional ultrasound machines is that this is crystal-based. So it has a large, what's called piezoelectric crystal, which is a very expensive piece of technology. It's a crystal that vibrates at a certain ultrasound frequency and gives you the ultrasound signal. Each one of the probes that attach to this machine usually are about $10,000 each. In contrast to this device, is based off of a silicone chip that each portion of the chip vibrates at that ultrasound frequency, and because it's a silicone chip, it's a lot cheaper. It's like what's in your iPhone. It only costs here about $2,000 a day. Big difference is the image quality here is obviously a lot better than this one, but this is a tenth of the price. This is really portable. So this was a huge game changer in the industry of ultrasound, and specifically global health ultrasound applications. So it actually timed out perfectly where I did my fellowship in POCUS right when this device was really hitting the market, and that's where I tried it out in a bunch of different places. So I was really interested in low resource settings, which included my own home in Philadelphia. So this is me on a home visit, seeing a veteran, where on the home visit you have nothing. You have your interaction with the patient, you have some tools you bring from your office, but there really aren't any other diagnostic tools. And so the question I was wondering was how can we apply it there? Then I also went to Bangladesh, I went to Yemen to teach courses on basic ultrasound and using that device specifically in those settings. So Bangladesh in 2019, you can see sort of the state of the hospital. This is actually the largest hospital center in the entire country. It's in Dhaka, and it's this massive complex with thousands of patients a day. So I went with one of my colleagues and taught ultrasound to their physicians there. We came back a year later with a bigger group, taught more ultrasound and to more people in a bigger context with some of these experts, which was fantastic. I also went to, as mentioned, Yemen, which is this awesome action photo they caught of me and my mentor, Lorraine, looking like really cool missionaries. Really just a bunch of nerds coming to teach some ultrasound to some other doctors. And so yeah, it was a lesson in sort of how this technology can be used, and also some of the pitfalls of it, how it can be the future of using ultrasound in these really low resource settings. So initially I had that fork in the road when I was my early 20s, and now closer to age 30, I finished my training. And now I have to figure out what I want to do in my life. So the fork's sort of turning to many different paths here, because it's I could either go to the MSF route, I could go start a job in Philadelphia, I could just do something completely different. You realize that as the years pass, the decisions don't get any easier. They get more complex and more convoluted, but that's also a good thing because it opens up a lot of really interesting experiences. So I wanted to create a career from Philadelphia, but also still with a global health perspective to it. So I took a job at Pennsylvania Hospital, which is the first hospital in the United States that Ben Franklin founded. So it's a really beautiful building in downtown Philly, an old city. But I specifically, and it took a job specifically teaching POCUS to the residents. But what was really nice is that I can use some of my funding there to do 2 weeks per year of teaching ultrasound abroad. So this is in Uganda. This is actually last week I was in Rwanda teaching. So it was a nice way of incorporating that global health interest of mine in a sustainable job in an industrialized country, but having to completely upend my entire life and change everything of what I love about living in Philly. So just some more examples. So back to that refugee settlement. This is Uganda. This is the site that is located near Lake Albert. This is the level of poverty that we're dealing with. So these are refugees from all of the surrounding countries, and they live on about $4 a day. So the resources are extremely limited. I'll just show you one point I wanted to make for you, since I know that not everyone here wants to become a physician, is that you don't have to be a physician to get involved in this. The humanitarian group that I was with, we had some doctors, but we also had plenty of people who had other experiences in business and humanitarian work that contributed to it. And I thought that was actually one of the most powerful parts of these missions, was to have that part of it. So these are some more pictures of the sites. I had a rush to run out of time, but this is sort of the level of inequity that we're dealing with and where the relevance of applying this technology comes into place. Because it's portable and it is super useful. There's some more cases, we'll skip over those. And most importantly, I get to be a mentor now because I'm getting old, and now I get to train the next generation. This is Juan, he's one of the residents that I trained from Pennsylvania Hospital. This is him last week with me in Rwanda, and he's on the same path to sort of figuring out what he wants to do next. So, and just for a fun little side note, I also run, I have a little Botox clinic in Philadelphia, but I want to bring up this point because I use all the proceeds from that Botox clinic to actually fund some kids to go to school in Uganda. So I think some of the values that I learned from 360 are still prevalent, even in the little side hustles I do. I still think about how this money can be used more effectively across the globe. And that's it. Those are the lessons I have to share, and I really appreciate you guys listening. Thank you.
Thank you, Alex. Okay, so next we have Christine.
You can take a breath now. Oh, all right, cool. Well, it's great to meet everybody. My name is Christina Lagos. I am an alumni. I graduated in 2018. And I am so glad that you mentioned the ultrasound, the butterfly portal ultrasound, because that is one of many really great pivotal point of care technologies out there. And a lot of my current clients are in the point of care ultrasound space, looking to continue paving the way forward from where the butterfly ultrasound started off. So really exciting. You guys definitely take a look at this thing during the happy hour. All right, I got 10 minutes, let's do this. So I work remote, and so I don't usually come in public a whole lot, so I'm gonna stay back here. I'm not a pacer. I am an Associate Regulatory Affairs Manager at Proxima Clinical Research, actually headquartered in Houston, but we're all remote all over the nation. I'm based in Seattle, Washington. Just moved up there about 2 years ago. It is dark, it is gloomy, and I am undercaffeinated. I did my bachelor's in biochemistry and cell biology, and I did the global health technologies minor. I remember going to the minor and majors fair in the rec center, and I saw the salad centrifuge thing, and I'm like, I want to do that. That's cool. I don't know what I'm going to do with it, but that's really neat, and I like tinkering. And so I guess I'm going to go into my whole career in just a little bit. But I also did my master's with the Global Medical Innovations Program the year after. And I currently manage a team of awesome associates with clients all around the world, developing early stage medical devices, biotech, in vitro diagnostics. And I'm also the portfolio manager of the SWPDC. When I was at Rice, I studied biochem. I did a lot of genetics research, and I thought it was pre-med. We'll come back to that in a second. And so my minor was in global health technologies, and so that's when I dabbled in learning about developing technologies for low resource settings with limited resources, and having to think about what are ways that I can develop this device to be sustainable and use resources and materials that are available in these locations, and And so even though it wasn't an engineering major, it still taught me all of these various concepts about developing devices with restrictions and thinking about your end user. And this became a recurring theme throughout the rest of my career to date. And so I worked on what's, I think is now called the SIA, right? It's the training model for cervical cancer. Trained all sorts of different diagnostic and screening tools for an otherwise like completely preventable cancer. And it was so cool. It wasn't a medical device, but I still got to go through all of the thought process and the design documentation of thinking about, okay, what does this device need to do? What does it need to improve? What is this made out of? How do you assemble it? How do you repair it? Can this be 3D printable? How can this be manufactured more sustainably? How do we package it up and ship it across the nation so it doesn't fall apart mid-flight? So all of these things that I never really thought about I'd get to do as a biochem major, and then realizing that that's going to become my life. So I remember we were doing a really great training session in El Salvador one winter. It was actually over Christmas. It was right before we dismissed for Christmas break, and my whole design team was there. And we were training local physicians and nurses and other healthcare providers how to perform all these different techniques using our device. It was so cool. We had them all lined up. And I realized that I really had an interest and a passion for gaining feedback from my end user and talking to them about, okay, what could be improved with this device? What other aspects of this technology do you need this to do? What would be, do you need more lighting? Does this fall apart too easily? What are other procedures that you want this to be trained on? And I really loved it, and I loved the brainstorming and the active collaboration and the back and forth. And I was just so excited and bubbly about it. And then I remember that night getting rejected from medical school. Yeah, laid in bed that night, and next morning my design team went out and got me like a coffee and latte, surprised me in bed. It was so sweet. But that's when I realized, okay, what's next? I really like what I do. Okay, I'll do a master's in global medical innovation as a gap year. It was not a gap year. And so the next year I did the Global Medical Innovations program here at Rice. I did internships at establishment labs working on medical aesthetics. So making breast implants safer, and also interned at the Johnson & Johnson Center for Device Innovation just across the street. During this time, I got bit by the startup bug and formed my own startup to develop and improve on the vaginal speculum. So kind of going along with that whole theme of women's health and a big passion for innovation in a space that hasn't been iterated on in a very long time. And during that, I think I also still kind of stayed involved with Rice360 a little bit, still participating in some of the training workshops. And so, let's see. And then afterwards, so it was just a one-year program. I was really stressed out about, okay, I don't have an engineering background, but I still have this knowledge of design documentation that I learned from the minor program and how to create low-fidelity prototypes. I learned about how to sort of form an initial business and business plans and strategy and early stage product development. And that kind of led me to my next role at Bonnel Innovation Studio, also here in Houston. I entered as an entrepreneurship fellow, and I got to work on a whole variety of different technologies, from fetoscopic surgery, so spinal bifida repair in fetuses before they're even born, developing devices for cardiovascular catheters, in vitro diagnostics for COVID, neurological implants, all sorts of different things, learning how to develop low-fidelity prototypes and writing grants and trying to gain some funding for it. Basically, a lot of little startups under one roof. So it's fast and rapid and exciting and lots of failures, a lot of wins and little pivotal changes here and there. I got to dip my toes into market research and how to manage a team. And then from there, I got involved with the Southwest National Pediatric Device Innovation Consortium, the SWPDC, which is a FDA P50 grant founded consortium. There's 5 in the nation, and so what the SWPDC does is they help support pediatric device innovators from all over the nation to provide resources such as funding or regulatory support, reimbursement support, connections with clinicians to help them get their device through the market. So I got to help set up some of the behind-the-scenes databases, run some of the pitch competitions, and meet all sorts of different innovators and try to figure out for them, okay, what do you need to basically, what I like to call the Mario Kart speed boost to your next step? What's going to be the most impactful? So taking all that knowledge from learning about your end users into device development and and business startups and what does a company need. So leading that into my current role at Proxima Clinical Research, basically I wrestle with the FDA. All of my clients are very novel, early stage, trying to get their device, trying to develop a safe and effective device to get through regulatory hurdles. Some global, but being based in the U.S., FDA is their bread and butter. And so, when you're a CEO of a small startup, you always say, "Here's how my device is very different from the competitors." Whereas with talking to FDA, here's how it's exactly like the next thing and how it's exactly the same safety and profile as everything else. And a little bit different here, and here's how we're going to test it. So I get to help mentor and coach my clients through those steps. We're a consultancy that helps. Oh, I have 1 minute. We're going to speed through this. That helps. I lost my train of thought. Here we go. Okay, we're gonna go on. Okay, cool. Yeah, so just a little bit more about Proxima. Yeah, so we are both a regulatory consultancy, quality management. So again, thinking back to all of that wonderful design documentation you're gonna do in senior design, that's gonna come back and be a recurring theme if you go into medical devices and development because it is a highly regulated field. We're also a clinical research organization, so I get to learn all about how clinical trials are done. If you guys are interested in learning more about pediatrics and clinical trials, I am also going to be at an event on Thursday over in the NMed building for Texas A&M with the SWPDC to talk more about clinical trials. So it's a free event on Thursday if everyone's interested. So we've got over 350 companies across the nation that we help out, across the world that we help. So a little bit more about what it takes to be in a role of regulatory affairs. You do a lot of strategic development and interacting with the agency and writing all of those wonderful deliverables that shows what our client is developing. And then also post-market surveillance of, okay, you've got this device through the market, now what? Monitoring for any recalls, safety issues, all through the entire lifespan of the device. Okay, last slide, I promise. Okay, my top 5 career learnings, if you take anything away from this presentation today, I hope it's these 5. Network, practice networking, make a LinkedIn, meet people, stay in touch. It's not that scary. Just hang around the food at the events and just start chit-chatting that way. People love talking about food. Identify during your career what you like and dislike doing. This can evolve over time, and that is absolutely fine. In fact, I encourage it. I don't like reading patents. That's what I discovered. Stay up to date with global industry trends. Things are changing all the time. Think about the rise of telemedicine during COVID. Everything is constantly changing and iterating. And so as you go through your careers and even your time here at Rice, just keep on top of what's going on now and how is that impacting global health right now. And also, your career path may be non-linear. This minor program opened a door that I thought life was just like pre-med and med school and I'm done. But there's so much more that you could do as well. And every experience plays a role in your unique toolbox of strengths. Every single experience you have, whether that's being president at Rice or being playing an instrument in the Rice marching owl band like I did, all plays into all of your strengths, whether that's soft skills, hard skills, and so forth. And lastly, step out of your comfort zone if you want to learn. You're going to be a little uncomfortable. It doesn't have to be like jumping into the deep end, just like a little toes, okay? But I highly encourage you to step out of your comfort zone and explore and learn and grow and take advantage of the different resources here at Rice. And that's all. Thank you.
Thank you. And Christina.
Thank you. Good afternoon, everybody. How's it going? Let's see. Should I use this to advance? There I am. I'm Christina Triantaphyllis. I am a proud alum of Rice, class of 2008. I also was at Rice College. I have since spent a lot of time at Rice in various ways that we'll talk about today. I am also a proud member of the Rice Advisory Board and have had the opportunity to stay in touch with the organization since it was beyond traditional borders and watched it grow and flourish into a major, large-scale global organization that I'm so proud of. So I'm glad to be chatting with you all this afternoon. I think I'm going to skip my cheesy icebreaker and show you guys are interested in that. We'll get to it later if we have time. So as I was reflecting on this, I also got a chance to dig through my 2005 hard drives and find some old photos, and I really was reflecting on the ways that Rice has shaped me as a person overall in countless ways. I met my husband at Rice. He was also at Rice. I realized we both couldn't be in Captain at the same time. We were different grades. But that kind of fast forwards to our family here on the right. I've got 3 little kids, live on the other side of Herman Park, so not too far away. And all throughout the years, Rice has played a special part in our lives. One of the other things that I was reflecting on was that the time at Rice and at Rice360 really set us up for bringing other people into Rice. And one of the examples of that I'll talk about a little bit was that my husband and I founded an organization called PAIR, Partnership for the Advancement and Immersion of Refugees, which I believe is still a organization on the Rice campus. It's now a nonprofit in the community, and one of our most memorable moments at Rice was having an annual and regular occurrence at the language. Is there still a language resource center? Does it still have a Rosetta Stone-like technology? Oh, that's awesome. We were able to bring refugees in Houston from all over the world onto the Rice campus to learn English, which was a language they had to purchase in the language resource lab. There weren't many Rice students learning English. But all that is to say is that Rice has really shaped my life, has shaped the lives of a lot of folks in the community as a result, and for that I'm very grateful. Specifically about Rice, I'm not just saying this because I'm here as an alumni panelist, but Rice360 was my most impactful experience as an undergrad, and I really broke that down for a lot of different reasons. I was just reflecting on this. It was the most illuminating experience in terms of helping me identify what I wanted to do next, because the coursework and the summer experiences were extremely real. These are problems that were facing the most vulnerable in our entire planet that we as students had the chance to humbly design solutions to. Now, did we come up with the right solutions? No. Did we learn a lot in the process and meet incredible people? I remember Skyping with people in Lesotho at the time. I think Skype was probably new at the time, and we were trying to figure out the context of the place that we were trying to eventually visit and help. And this is all as an undergraduate with very little experience, but getting in there and understanding and learning through courses that were grounded in reality, through mentorship and career exploration. And I just can't emphasize enough, if it's not this, find that thing for you. Find the organization, the experience, the summer internship that helps to bring to life the thing that gets you going and gets you excited. And if you're not finding it, I think as somebody else already said, keep looking for it, because that means you just maybe haven't met the right person or tried the right thing. And I think that's something that I am forever grateful for, and pictured here in 2007, Rebecca and Maria and my friend Sophie, we're still friends today, in our internship site in Masero, Lesotho. It was also at a Baylor Pediatric AIDS Initiative site, and across the street was a SOS Children's Village, which is essentially an orphanage that is comprised of homes, so children are in homes with caregivers instead of in a large institution. And in that place, we were tasked with dancing, hip-hop dancing. We were tasked with probably the lowest tech question of any Rice360 project, which was to design HIV/AIDS prevention curriculum that was engaging for adolescents to help them understand the biological process of HIV/AIDS transmission, how to prevent it. And in doing so, although it was probably the lowest tech question, I think maybe one of the biggest lessons learned applies to a lot of the tech questions, which is that it all centers around strong and trusting relationships. We still had to build relationships with the clinic staff, who started every morning with a beautiful prayer and morning song, and it was just such an inspiring place to work. We had to build relationships with the children across the street and their caregivers. And yes, through dance and through other ways of connecting, we were able to come up with the curriculum. I did not bring the animated version of it. There was like a virus moving around and an immune system and attacking involved with like very PowerPointy animations. I'm embarrassed by it, but we did it, and we made amazing relationships along the way. What's not pictured here is something that I think has been alluded to before. While I was learning and exploring, I had a pivotal sort of moment in my trajectory, which was that I, too, was a pre-med in denial. I still thought I was going to med school while I was in the Institute. I had my MCAT book with me. I was getting ready to take it after my, somehow, travels. And it dawned on me that I both did not want to be a doctor, and knowing that I was in the most humanitarian place where you could work with the most vulnerable children, I realized that this is not the kind of, medicine I want to practice. I definitely do not want to be a doctor. But if not this, then what and why? So there was a moment of panic. We were at an event in a diplomatic State Department site of some kind at an embassy, and there was a GRE book on the shelf, and I guess I kind of stole it because I took the GRE book, and I was like, well, I guess I need to study for the, some other exam. And then I was like, I don't know what to do. And so basically, I realized that Rice360 and this experience had really introduced me to a different discipline altogether, which is public health. I had not really, known what public health was. I was learning a lot more about it, but not putting a name to it until I was in this program. And long story short, I began what has been a career in kind of population level change through the public health lens. And that moment of panic was one that I am glad happened there, I guess, away from my parents. So I'm not going to go through all the details of this slide, but the key theme here is that for every moment of transition or change, I realized there was a, if not this, then what and why, kind of like the med school realization. And all along the way, I was sort of, asking myself these questions, what do I want to do and why, and is this helping me to impact the most number of lives possible through something that I can genuinely contribute? And if that's not, being a physician, what is that? We talked about the refugee nonprofit, which I think Rice360 really helped me to feel the confidence to keep working on that and design solutions for problems, again, that were local but impacting a global population. I loved my graduate school experience in public health, and I focused on maternal and child health and newborn survival. The other thing I'll mention about my being a pre-med in denial and why doing things to figure out what you don't want to do is important. I fainted a lot at the Baylor Pediatric Clinic in Lesotho, and these were not gory, bloody situations. It was just me feeling a sense of discomfort with even someone's emotional states. I realized very quickly that even a social worker wouldn't be something that I could handle. So that continued my journey into understanding what's my role in maternal and child health. I got a chance to work in Nepal with an organization called John Snow Inc., which is a development consulting firm that at the time was working on a Gates and Save the Children project to reduce neonatal mortality through female community health volunteers. I love that. I realized it was bringing together an idea, piloting a solution in one place, figuring out if it's effective, bringing it to scale, working in concert with a lot of organizations. That brought me to the Bertrand Group, which is a social sector consulting firm where I got to work on everything from foster care, youth development organizations, sports-based organizations, World Vision. We had a client, we worked with KIP and Yes Prep, all sorts of education and health organizations. But what I realized there was most of our clients, especially the philanthropists who we were advising, always had the question, my incremental dollar invested will never be as impactful as government dollars. Even if I'm a billionaire investing, majority of my philanthropic investments every year, it will never compare to what governments, especially the US government, can invest in solving a social problem. So how do we influence policymakers to do what we're trying to invest in through these nonprofits? And so that had sort of taken me on a path to, if not advising a social sector organization or philanthropist, then advising government or being in concert with government. And that has what brought me the last decade to work here in Houston at the Collaborative for Children, which is an early childhood nonprofit, and most recently at the Texas Policy Lab here at Rice, actually, where we try and create partnerships with government to answer their questions and try to get at a more collaborative approach to policy change, which I can talk more about later. And since time is running out, I thought I just would kind of go through some of these reflections. Maybe there are too many, maybe I'll pick my favorite three. I will talk about the third to last. The decisions that seem extremely consequential in the moment are very unlikely to determine the entire course of your life. I remember being around your age and thinking like, oh my God, there's no major that I like, what am I gonna major in? What am I gonna, and then it's like, no, nobody's even asked me my college major ever. Like, has anybody asked you? Okay. Then, when it's like, what graduate, if you get into more than one, which am I gonna go to? Or if you get into none, what am I gonna do? And every single time, it's like, if I would have just taken a step back and realized that there are these other potential routes and that nothing is deterministic of anything, I think I would have been, a little bit more enjoying the moment at the time. And please do enjoy where you are, because you'll never have the chance ever again to be in a room full of very interesting, intelligent people and professors, and a place where you're just here to learn. So please do enjoy that. I think the other one I'll point out is that making meaningful or important progress on a significant challenge, the second one, takes no less than 10 years. I'm an impatient person, and so when I would start working on something, whether it was a consulting project at Rice360, where we had like 6 months to design a scaling plan for an organization to, improve neonatal mortality in however many years, it's like, wait a minute, nothing that historically has ever made a major impact in the world takes less than 10 years, and somebody had, explained this to us with the Affordable Care Act and how long that took to implement. And so when I found myself getting restless in jobs or projects or things that are taking a long time, as they did in the policy changing realm in my most previous experience, I have to kind of remind myself that if you really want to be in it for the long run, you got to be in it for the long run and be a little more patient. I think I'll just stop there, probably another time, but I'm happy to talk about some more of these and chat with you after. Thank you.
Thank you all. Thank you all for sharing everything. I feel really validated right now. I did all of these things in class. And so, I learned a lot. I hope all of you got some good nuggets out of that in terms of life advice as well. Especially, you'll probably panic at some point, but they all figured it out. So to get started with a general question for all of you to answer. So how have your interdisciplinary backgrounds and global perspectives influenced your work?
Well, I think the fact that the Rice360 program is built upon bringing people from all sorts of different majors already introduced me at a very young age to learn to work with people who are super different from me in terms of their interests and their skill sets. So all the project building that we did in that final year, I was with a group of engineers, and I was a sociology major, so I didn't at all have the same perspective or background as they did. We still found a way to work through things and come up with a project. So I think that was a really useful introduction early on to how many different types of people and skill sets are needed to accomplish some of these projects.
Absolutely. On my senior design team, we had no engineers on the team, but we all, at some point, knew how to use a screwdriver, and we learned how to use the laser cutter. We were proactive in taking all the makerspace classes in the ODEC on the weekends, and we pulled from each other's experiences in public health and psychology background and all that, and both from our background and how we work as a team together. And so I found it very valuable in moving forward, working in teams that aren't just engineers or aren't just medicine. It takes a whole village to bring a technology to market. And so I have really enjoyed learning about, everyone's going to have a piece of expertise at the table, and it's really exciting to collaborate with everyone. And so keep your ears open and welcoming other experiences, and that's something that I definitely enjoyed learning during my time with the minor.
I'd say two things. One, I learned that I wanted to seek out interdisciplinary teams. So I think in every career choice I made, I consciously thought about that I wanted to be in community or on a team of people who work very differently than me. I think that's been most of my most rewarding experiences have been like that since Rice360. So I do seek that out. I'm actually in a career transition right now, and I am actively looking for something like that where I can be, in a team of people who aren't like me but who can all offer unique things. The second thing I would say about it is that it gave me the confidence to realize that, just because I wasn't an engineer, I did have value to contribute, and in fact, in my most recent role with the Texas Policy Lab, I was the only non-economist working with economists, and there's a lot of opportunity to feel like you're lesser. But what I realized was actually the way we could have impact with policymakers was only if we could communicate and create strong partnerships with them, and that required people who came from different disciplines, who could translate the econometrics, who could help to define the complicated research methods in ways that were accessible to people, whether it was through visuals or through other means of communication. And so it was a lesson and in confidence in what your unique kind of contribution can be.
Okay, so now I'll get to specific questions for our panelists. So I'll start with Christine. So in our 2-1 class, we made a prototype as part of our hackathon, which I thought was fun. I think everyone else had fun too. But afterwards, they asked a lot of questions about the medical device industry and commercialization and that whole process. So at what stage do companies come to you for support, and what support does your company give them?
Mm-hmm. So whenever a company is starting to engage in planning their regulatory strategy, I always encourage companies to start thinking about this early on, as it can get expensive and you have to think about what testing you need to do, what are the fees and other documentation necessary to get yourself from prototype to market. And so as you're raising money for grants or investor dollars, starting to think about regulatory. So I get this question a lot from my clients actually, because some of them actually, like one of them I talked to today came from a capstone class, or some of them came from a research out of an academic institution. And so they always ask me, what is too early? What's the sweet spot? And it's like, I call it a Houston design freeze, where it's kind of frozen, but it might unfreeze. And so you want to be able to make the most out of your regulatory interactions and not having to backtrack. And so you have to have your design is set, and you don't plan on making any more major changes. Like if you know your output's going to be, and you know what some of the major features that would impact your safety and effectiveness of your device. And so think about that in mind, especially as you're planning, what are the next steps for this technology? Do I have to start having a lot of testing? And so that's the sweet spot. Great question.
Thank you. And just a quick follow-up. So with testing, where does that normally happen? Because you mentioned you're a CRO as well. So do you do testing at where you work, or where do people get their testing done?
Yeah, so we don't do the testing itself. There are some manufacturing and testing third-party laboratories out there who can do testing per ISO standards and other things just that follow specific protocols to demonstrate that the device is safe per this industry standard. Testing can be benchtop, it can be animal, it can be clinical, just depending on the nature of how risky your device is. So as a clinical research organization, we currently don't have we don't do the execution of it, but we do validate the protocols and the results to make sure that this is going to check all of FDA's boxes or any other global regulatory bodies, depending on where that company is planning to go into. And then also we can support any and all needs for planning a clinical study, whether that's the on-site startup, the management of the documentation, the writing and planning of the protocols and the follow-ups, etc. And so, yeah, so when you start thinking about your testing, you want to think about like what has other similar devices to yourself, what have they done, and leveraging that as a resource. And then of course, thinking about what testing you need to do as you go through how much funding you need. And the sweet spot for this is after you've got an actual design freeze, you've got a quality management system set up, it's a whole thing.
Great, thank you. Okay, Christina. So you work in policy and you work with the Texas Policy Lab, and so how do you ensure that your data effectively informs policy decisions?
Great question. First of all, you can't ensure it. It's very difficult to kind of make policy change always in a rational and systematic way. However, what kind of attracted me to this way of working was what I observed with the limitations of my previous role. I had a legislative advocacy role at an early childhood nonprofit, and part of our job was every session to come up with a legislative proposal for how to improve early childhood outcomes in Texas. And we thought we had the best idea ever, and we made it into a bill, and somebody sponsored it, and all along the way there's such room for error, the bill being watered down and dying along the way. And it also felt very antagonistic with policymakers. What needs to happen, and this is what you should do, and et cetera. In this approach, it was very much in order to more effectively get to a policy outcome that we thought was rational. We started a relationship, with the policymaker or the government agency at the center of the questions. I was like, what do you need to better understand about your policies or programs? What is something that you would like to improve? In the case of the Texas Department of Criminal Justice, they wanted to understand if prisoners who completed their sentences and also participated in a workforce development program were better off. Okay, better off in what ways? Were they employed later? Were they not in jail later? And so then they said, what would you do if they answered that question? And they had to think about that. Okay, what data would we need? They thought we could just run off into the census data and answer that question. No, actually, you have the data on who was released, and we would have to merge that with workforce data, and we could do that, but what is it that you want to learn and why? And what would you do with that information? And so having those conversations upfront in like a trusted, structured way, and making it clear that it's their research and not ours. I think a lot of times they work with research like, oh, you're going to go off and publish that, and that's great. No. If we're going to work together, this has to benefit. This is the model that we were trying to establish. That wasn't academics for academics' sake, but research that would inform policymaking and having their policy agenda at the center, or their research question at the center of our work was kind of the biggest factor for success. And lots of things could go on along the way that wouldn't work, but that was a key to at least getting it going.
And how do you take kind of this academic research and present it to policymakers? Is there like a translation process, or kind of like what is important for them to see?
Yeah, so the first thing is that seeing things along the way is helpful. So lots of times I think in academic research you have to wait 2, 3, 4 years later, especially if you're following a cohort, to get the results you want. I think government timelines don't work that way. They want to make a decision alongside a budget, which is usually an annual cycle. So one of the things we would do is make sure that even if we don't have the full research result ready, if we clean the data, we learn a little bit about their population, even if it was descriptive, share that with them. That could inform a short-term decision. So that was one of the things, kind of sharing information regularly. The other thing is being able to communicate, like, there'd be a technical paper that was going to be maybe submitted to a journal. Okay, what's the three-page summary? I didn't really realize executive summaries weren't a thing like this. But what's a 3-page summary that, a legislative assistant or even a government leader who has no more than a bachelor's degree, like no statistical training, could read and understand. So we spent a lot of time figuring out kind of the 2-page version that was acceptable academically still, but kind of summarizing the technical pieces and limitations. And that actually proved to be very difficult. There's a lot of back and forth about what can we say and summarize in a way that was overly simplistic. And so there aren't any good blueprints for that. But we worked together kind of to try and do that, and then got the feedback along the way too. That this still doesn't make sense. This is still written for a econ grad student, or by a econ grad student for an econ audience. So yeah, it was definitely a learning process for all of us.
Great, thank you. And Alex, so we have a lot of students in the audience that are all different majors, from engineering to sociology. And so, do you think the intersection of your sociology BA and your natural sciences for your MD education enabled you to become a better physician? If so, why?
There's no question about that, absolutely. And that was the reason I remember I was originally going to do like a biochemistry major, but I was like, this is the only time in my life where I get to study something completely different and learn about a different topic. So I chose sociology with the idea that I was going to go with medicine, and thinking about the fact that there are a lot of actually, medicine is so much more linked to social issues, I think, than I realized when I was 17 or 18 going to college. Like, yes, you have to have obviously you have science knowledge, but like my ability to assemble like an organic chemistry molecule has zero, like that did not end up panning out to be very useful later on in life. And what matters much more is understanding like what are the social inequities that exist in our society, what are the things that specifically affect marginalized groups in your city. So I think like I had an awareness of that early on, and definitely informed the type of job I was seeking and the patient population I wanted to help.
Great, thank you. Okay, so for all of you, this next question, what emerging trends or technologies do you see having the biggest impact on your field in the next 5 to 10 years?
You're just gonna say AI. Oh, dang it.
I think for me, I split my job into two aspects. So there's my job at the hospital and my job in global ultrasound, or at least my interest in global ultrasound. So for the job at the hospital, yeah, it's going to be AI, right? There's no question about that, in the sense that like I use it every day at the moment, and it's incredible in terms of its ability to come up with a differential diagnosis that I had not been thinking about. So I think it makes me better at my job, and I have no shame about using it because it helps fill in some of the blind spots that I may have when I'm thinking about patterns and trying to put together or solve a puzzle. And then for ultrasound, this will just get better. I mean, every technology just evolves rapidly, doubles volume quality every few years. And so the images will get better, and eventually we get to a point where you can get as good images on this as you can on the current cloud-based machines. So I mentioned those two pathways are what's going to affect my job the most.
Yep, AI ML. Every month, FDA is releasing new guidances as an effort to keep up with innovation in this space. They just released a final guidance today about what's going to be appropriate to retrain models after you've brought a device to market. So definitely AI ML for software as a medical device and integrate it in current software. So that's been a huge one, and especially in the field of medicine, trying to understand what's going to be an appropriate and ethical way to integrate this into technologies. What does FDA want to see as they're training their models? What demographics? It's going to be an ongoing, evolving discussion. Definitely the rise of telemedicine and point-of-care technologies, as you guys have seen with the ultrasound, and lots of other technologies as well, enabling mobile phones, and then lastly, the technology, electronics becoming cheaper, miniaturization is going to be really, really neat in the next 5 years, decade.
I won't repeat any of that, but I guess one thing that is not necessarily a trend, but maybe is being like implemented better, is from my observation in like various policy domains, from criminal justice, early childhood, and human services, is kind of this acknowledgement that everything is interconnected and interdisciplinary. A person's health is probably more determined by their social environment and conditions than biological mechanisms. The same can be true for their kind of, think about any other area of social policy. And so I think what's happening is the like sort of social science or understanding of that has made it beyond just the understanding of it to now how can we upfront design policies or programs that take that into account, so that somebody who comes in for a health screening is also introduced to a housing expert or a early childhood development specialist, like all kind of in the same location, or if it's virtual, kind of having all those things a little bit better intertwined. I know that sounds basic, but it's been like not executed very well a lot. Has not been executed very well at all, and I think is getting kind of is a bright spot for improvement.
Great, thank you all. So now we'll open up to the audience. So if you have a question, raise your hand and we'll give you the mic.
Hello. Okay. Hi. Can you see me? Okay. Okay. So you all talked about AI a little bit, or kind of touched on AI, and I'm part of the Rice360 team, and so very technologically focused. And I'm also in doing a public health master's, so also very much in tune with what you were talking about. I guess my question is, we've seen a lot of AI be biased by our own human biases. And so I would be interested in hearing what your thoughts are, concerns or otherwise, about the increasing reliance on AI or interest in AI with the knowledge that there is such bias in it.
With the context of technology, like medical devices, or within like physician input, or
All of the above.
okay, I'll start since I have the mic. So definitely, like I said, like FDA has been really careful about like how are these getting trained, and so what, especially my role in being in regulatory, is I want to make sure that the client is developing and training their models and being aware of all the different factors that could potentially bias the outcome, and how are they developing their model, how are they testing their model, and how are they validating their model, and making sure that and confirming early and often with regulatory bodies that, like, hey, is this an acceptable representation? So for example, is this going to be representative of the target user, sex and racial demographics, geographical demographics, even how big of a hospital or clinic or home care is going to be used by, and this is going to be able to be used safely in usability testing to make sure that can the user interpret the outcomes per intended. So it's going to be really interesting, especially at, like you mentioned, like moving forward in the future. I see a lot of activity in the radiology space, especially of being able to use like software that targets, like, hey, I think this area might have a tumor, this might be cancerous, look into that. FDA has also, there's been gradations of different types of software as a medical device for computer-aided diagnostics and devices, whether that's going to be specifically diagnosing or it's going to be an age diagnosis of like, will this, can this identify it, can it triage it, all these different subsections and ways to think about, okay, what specifically do we need to, will this device be able to do? And so it's a lot of changing things right now. So definitely keep that in mind and keep questioning it as well.
From a perspective of a physician practice, I think like currently AI is still so much less biased than humans are from my experience, like in the hospital. The amount of implicit bias that I observe with my residents, with patients, with nurses, with myself at times, it's so much more intense than what the software does. So I think that's part of, I think, where AI is going to be like sort of sectioned off in medicine. Like, let's just focus this technology for diagnosis because it actually is really helpful for to take off sort of remove the implicit bias that I may have as a person walking through and seeing another human and assuming all sorts of things about them, and just putting in the facts of the case. I say this is a 36-year-old woman with these symptoms. Help me think of like other diagnoses I'm not thinking of. I think that's where it really thrives, and I haven't witnessed any bias in that. If you were to push this technology, say like, okay, now to tell me how to counsel this person, like how to talk to them, then I think you're opening a whole like can of worms of weird sort of biases that are going to come into play. And so I think that's where I feel a little bit okay about the fact that I have some job security in the future, is that you'll still need a human to talk to you. And I don't think that you're going to be able to reliably replicate that with AI. I always hope not, because I'm really out of a job. And I think like that's how we're currently mitigating the bias of that technology in the medical field, is by really focusing on just very fact-driven diagnoses that are not are less open to implicit bias than humans are in actual practice.
If anything, you can keep your job as training the models and as being the clinicians that are part of the training team of how many clinicians agree that this thing has cancer. So we've got some job security, don't worry.
this is actually for Alex. As you were presenting about POCUS, I was reflecting on some of the lessons we've learned with NEST, and I would love to hear your reflections on, or just have you share a little bit more about what the training looks like. Because when they say, "Oh, I go and I train them," and all of a sudden magically they're do ultrasound. How long is the training? How many repeated presence? What are some of the hardships with I guess the stickiness of it, right? Changes in management and staff turnover, sort of the things that you didn't expect, the sort of imperfections in the system that led to the true change.
Yeah.
In uptake.
This is that is where a lot of my cynicism in global health developed, because I went to Uganda 3 years in a row to train medical officers in how to use molecular ultrasound, and it just for one, they weren't interested in learning it. I think was a really big challenge, because they're already far enough in their career, they had their fixed ways of being, they didn't really want to adapt to new technology. And I think we're only there for a few days, we're not giving them a very intense course, it's more of a hands-on instruction, and then there's no Wi-Fi there, so when I would leave, there'd be no way for me to actually review their images to give them teaching and feedback on that. Other sites that, for example, one of the groups I worked with was Med Global, and they had more longitudinal sites, such as Yemen, where they did see some progress, but still the same technological barriers where the Wi-Fi wasn't strong enough to upload videos to get feedback. So I can say that in my job in Philly with residents, that, just witnessing how long it takes to see proficiency, each person trying to learn how to use molecular ultrasound, you need at least 25 scans of each type of scan to get even a basic proficiency in it. And so that is simply not very realistic in a 2-week mission showing up to teach some basic stuff. The most recent trip I did to Rwanda was the most promising one, because we were teaching medical students who had already had molecular ultrasound incorporated into their medical school curriculum at the University for Global Equity. So they already had basic skills, and so my role there was much more just assessing their abilities and teaching them additional tricks. So it is like many other things, a very longitudinal process. And at times, in certain places like Uganda, you even wonder, is this even what we should be doing? Because they don't even have enough hand sanitizer. Should I just focus all my efforts and do they really need a $2,000 probe, or do they need $2,000 worth of disinfectant to actually change their outcomes there? And that becomes a really disheartening aspect to introducing these technologies. That sometimes it's even though it's a low cost simple solution, it still might be way ahead of what their actual more urgent needs are. And that's one of the challenges that I've realized in this.
Hi, my name is Mahtab. Thank you guys for a wonderful panel, and thank you Rice360. I'm actually not in the program. This is my first exposure, and I think I might be looking into joining the minor and doing the minor. But Christina, my question is to you. You work in the intersection of policy and medicine, and that's a field that I'm interested in exploring. How do you know that you're making progress? I know bills are very slow to go through, if they do ever go through. So how do you know that the work you're doing is actually making a difference?
It's a really good question. I'd say that policy change happens. It starts at different levels. It happens at different levels, right? So a lot of times, kind of the best solutions come from one organization working with. I'll give an example. There's a program called the Nurse Family Partnership. I don't know if anybody's familiar with that, but it's a domestic organization that basically sends nurses to visit the homes of first-time low-income pregnant women to improve their prenatal and postnatal outcomes. The effectiveness of that program was studied over many decades with relatively modest numbers in clinical trials. So on the grand scheme of things, it was a small program, but because of its effectiveness, kind of demonstrated through randomized control trials, it became kind of the model for what's possible for improving maternal and child health outcomes for first-time low-income pregnant women. And that sounds like a program, right? Or a nonprofit intervention. But that eventually became policy, federal level policy in the United States, because it became a model. It became the standard for what federal funding for maternal and child health should fund at state and local levels. So basically there was a pool of federal funds that was designated to fund programs as effective as the Nurse Show Me partnership across the country. And so your question is, how do you know if you're being effective? Well, let's say, that was a client of mine when I was at the Bridge Strand group, or of Bridge Strands for a very long time when I was there. And so while I was not there myself, at the Nurse Show Me partnership, having the opportunity to advise philanthropists who helped to then scale it in 3 states, that then those states became the blueprint for the government to then say this works, to then see it across the country. That wasn't me. I played a little small part in one of the early teams, but the notion that one small thing can lead to a big thing, and you can count the number of lives that were part of this original pilot that then went on to be this $100 million funding stream that now is in every state. I mean, you could start to quantify it if you want to do it like that. Or you could just sort of take stock of sort of larger movements and trends, right? So there's 2 ways. Are there trends and movements that then, states set the stage for investing early in a woman's pregnancy? That's sort of you could sense the change without quantifying it. Or is it there are this many millions of women and children who are better off because this program now is federal policy? So I don't know if that answers your question, but that's sort of one example. And then your role in it could be at any number of the nodes in that story, if that makes sense.
Yes, thank you.
So that's all the time we have for questions. Sorry, I'm mic. Yeah, thank you. Yeah, so if you have more questions, we will be having happy hours. You can come and talk to the panelists then, or they'll stay a little bit after as well. I just wanted to ask one last question of everybody, and that is, what do you wish you knew that you know now? Wait, what do you wish you knew when you were students at Rice that you know now?
It's oh wait, what were the ones that didn't stick on my slide? Actually, it was something that Alex said. So basically, kind of what you envision what you envision it will be is not what it will be. But how you react to those moments when it's not moving in that direction, I think, is really important. And it's difficult to sort of train I think part of it is just being in the experiences to then become better. I really do think it's a muscle. Uncertainty is something that's deeply uncomfortable, but sort of the more instances of uncertainty that you encounter, and just kind of observing yourself and your reaction to that uncertainty, I think builds strength and kind of resilience for whatever is facing you, whether it's professional or personal. And there's been a lot of instances of uncertainty that I've been faced, and a lot of them are not professional. But I think being able to understand that uncertainty is not a permanent state of discomfort, but that might lead to something, better, and just kind of being patient in it. I also think that being comfortable with uncertainty is kind of a superpower. And so if you're able to be flexible, sometimes if you're able to kind of just wait a little longer for that, next thing, or weather that rejection in a certain way, that's sometimes something better comes out of it. So I wish I had sort of understood the value of operating in uncertainty sooner.
I wish I leveraged the Career Center. Being pre-med, I thought my career was set and I didn't have to make a LinkedIn or a resume. Start that early, and right now, start writing down your accomplishments, things you've done, clubs you've done, what you like and dislike. Even if you're a freshman, just start documenting it now. It doesn't have to be fancy. Do it in a Word doc, do it on a notepad, I don't care. Just start writing your story.
I wish I'd known that there's so much more to your future identity than just what you're studying or what you think you want to do in the future or what your career will be. Once you leave this campus and start to explore the uncertainty and the challenges that exist in life outside of the college experience, you realize that there is so much more to life than solely your job. There's a lot more complexity to it. There's a lot more interesting sides. There's a lot more people and skills you gain in the future that you probably aren't even thinking of this moment because you're just trying to get through the courses and get all the work done and sort of get to the next step. You get caught in this rat race that is important to sort of get you to the stages where you have some either like career stability, financial stability to explore other things, and that's important. But I think there's just a lot of other sides to you that you don't know yet, which is probably the fun part of being in your 20s, is you're sort of exploring those other sides of yourself once college is done. And I think I had linked my identity so much to like my major, my residential college, like my friend group, and then now 15 years later, I'm like, I became so much more than that, and I'm really happy about that. And I think I wish I'd known that, like, you're thinking like these are the best days and it's all done after this. Like, you leave the edges, you're sort of like in this new like scary world out there, but actually that's where like the real development really actually begins for longer term identity creation of yourself.
Thank you. Thank you all so much for that advice. Thank you all for your questions. So I'll give them a round of applause. Quick aside for people in my class, if you need to fill out the attendance, find the TAs up there to fill that out. And everyone else, thank you all for coming. And if you want to talk to them more, come to the happy hour at the hall.